Micro-CT, a new way to see cancer in a surgical specimen. Micro-CT is a three-dimensional, high-resolution, X-ray based imaging method that we have found can provide the surgeon and the pathologist with a new way to see where cancer is in a surgical specimen. Here, we've made the cancer red and the edge of the specimen blue. We'll explain how we did this below. CT allows us to see where in space X-rays are absorbed, and micro-CT allows us to see this at very high resolution. Visualizing the image requires the use of computer software. Here we have used the computer to virtually slice through a lumpectomy specimen from top to bottom. Cancer absorbs more X-rays than the surrounding tissue. While the radiographic physics of this feature of cancer is a topic of ongoing study, from a practical standpoint, this allows us to use computer software to visualize surgical specimens so that the cancer appears lighter than the rest of the breast tissue. Computer software allows us to view the specimen in 3 dimensions. Here we have used computer software to see the surface of a specimen in 3D, rotate it around and slice into it from the top. This makes it possible for us to see the cancer as a light gray region surrounded by normal breast tissue which appears dark gray. We can also use the software to visualize the specimen in different colors. Here we see surgical specimens from 4 breast cancer patients. We have used 3D computer image analysis software to visualize the high X-ray absorptive feature of cancer so that cancer appears in red while the region absorbing fewer X-rays, which corresponds to the margin, appears blue. We have removed the intermediate points corresponding to normal tissue and reduced the opacity of the margin so as to make it possible to see inside the specimen. The result is a 3D visualization of the cancer in red within a translucent blue surface. Here is another illustration of how we can selectively alter the color of the image based on the amount of X-ray absorption at different points in space. We have made the surface of the specimen appear opaque blue, the cancer appear red, and the remaining normal tissue appear black. As we use the computer to slice through the specimen, the location of the cancer with respect to the margin can be seen. But can we use this information to help us in cancer surgery? The goal of cancer surgery is to remove all of the cancer while removing minimum normal tissue. Whether or not the cancer touches the edge of the excised specimen, that is, margin status, is an indicator of the completeness of the surgery. If the cancer does not touch the edge, that is, margin negative, it implies that the excision was complete. If, however, the cancer touches the edge, that is, margin positive, it implies that some cancer is left behind in the patient, which is potentially lethal. As per our current management strategies, the pathologist examines a slice of the excised specimen under the microscope, and we find out whether the cancer touches the edge, that is, margin positive or margin negative. The disadvantage of this approach is that it takes 7 to 10 days for the result of the pathology report, and in 1/3 of the cases, the pathologist finds that the cancer touches the edge, thus indicating that cancer has been left behind and requiring the patient to come back for a second operation. Also, it is a small sample from the specimen, so the pathologist may miss a small region of margin positivity. In a number of breast cancer operations, cancer is left behind undetected and will grow back, increasing the chance of a patient's death by 22%, resulting in around 2,000 deaths each year in the USA. How can micro-CT help us in cancer surgery? We can use micro-CT to see whether cancer touches the edge. We scan the excised specimen, and in 10 minutes we can image the entire specimen. The advantage of micro-CT is that it can be done conveniently in the OR, offering the possibility to quickly determine whether the cancer touches the edge of the excised specimen, such that corrective steps can be taken in the same operation, reducing the need to reoperate. Also, since it is a 3-dimensional representation of the entire specimen, it offers the possibility to visualize the full 3D anatomy of the excised specimen, reducing the chances of missing a small region where the cancer may reach the margin of the specimen. We can slice through the micro-CT image in grayscale so as to see whether the cancer, which appears lighter than normal tissue, touches the edge. Here we can see that the cancer is well within the specimen and does not reach the edge, that is, margin negative. Here, as we slice through the image, we can see that the cancer is closer to one end of the specimen and in fact reaches the edge, that is, margin positive. We can also alter the micro-CT image to visualize the cancer in red within a translucent blue surface. Here we show two breast cancer surgical specimens, and as we rotate the specimens, we can see that the cancer is completely enclosed within the surface and does not reach the edge, that is, margin negative. Here we show 3D visualizations of two surgical specimens with the cancers shown in red within an opaque blue surface. As we slice through these specimens, we can see that both cancers are completely surrounded by normal tissue and do not reach the edge, that is, margin negative. This is another 3D visualization of two surgical specimens with the cancers shown in red within an opaque blue surface. As we rotate each specimen, we can see a red spot on the blue surface suggestive of the cancer touching the edge, that is, margin positive. As the surface changes from opaque to translucent, we can see that the cancer is located on one side of the specimen and appears to be touching the edge. And as we slice through the specimens, we can see the cancer touching the edge, confirming that the specimens are indeed margin positive. In our study, we carried out micro-CT reads for assessment of the margin status of 173 partial mastectomies and then compared them to the pathology reports. Both in terms of size and in terms of shape, the image of the cancer on the micro-CT matched the image of the cancer on the pathology slide with high precision. For cases judged by the pathologist to be margin positive, the micro-CT also showed an image of cancer that appeared to touch the edge of the specimen 93% of the time. For those cases judged by the pathologist to be margin negative, the micro-CT showed an image of cancer that touched the edge of the specimen 47% of the time. For these micro-CT only positive cases, the cancer occupied only 0.45% of the surface area, while for cases where both the pathologist and the micro-CT image suggested cancer at the edge, the cancer occupied more than 3 times as much space at 1.55% of the surface area. In conclusion, micro-CT provides full 3-dimensional images of partial mastectomy specimens, which can allow one to identify in a few minutes and thus potentially while the patient is still on the operating table, those cases which are margin positive, together with information on where the cancer touches the edge in a fashion that is more accurate than is possible from the histology slides alone.